the heat is there or heparin resistance there, in that case you can use, instead of heparin you can use direct thrombin inhibitor, that is bivalvuloidine. Argotabane also can be used, but that is not available in India. So what you can use is bivalvuloidine. Per hour, sorry. Some do's and don'ts of ECMO. You should always, in ECMO time, you get a lot of time, many dilemmas, what to do and what not to do, and you have to balance yourself. If you do something which is going to benefit, do that. Don't do anything to harm the patient. What is do is set clear goal with your priority. You should have a very clear goal in your mind, how much saturation you want to maintain, how much hematocrit, how much hemodynamic supports you want to give. So that has to be very clear what you want to achieve. So it starts with what you want to support, whether you want to support lungs or whether you want to support heart. So that is again important decision. So if EF for 25% patient goes into ARDS, does not mean that you start with VA ECMO. Because the primary problem at present is ARDS, not the EF of 25% long back. So you start with VA ECMO. So first you have to have a clear goal in your mind what you want to do it. You have to be very aggressive for first 24 to 48 hours in managing the patient. Okay. So whatever amount of fluid you require to give, you keep on giving the fluid because that is the only way you can get the flow. So don't worry about it. You have to aggressively treat the patient. Utilize golden period of intervention, which is must. Okay. That is again important. When if you need to intervene, even if you need to intervene surgically, there is a golden period of intervention. If you want to do surgical interventions in a patient on ECMO, it is best is to do in first 2 or 3 days, because then you are dealing only with heparin. There is the number of days increases, you are going to deal along with heparin, you are going to deal with coagulopathy also. So if at all you want to have some surgical intervention, you have to do it within first 2-3 days, because that will be more safer rather than going on day 10 or day 8. Because then the coagulopathy will also set in. Platelet count will be low, then you have more problems. So if you think your patient is going to need something, you do it in first 2-3 days. Tracheal toilet, especially permanent hemorrhage, repeated bronchoscopy if required. That's the most important. I have seen most of the time what happens is patient has a pulmonary bleed, and usually your chest physician or bronchoscopy people will say, no, we will not touch the patient now because it's a bleeding. Bleeding is a contraindication for bronchoscopy when the patient not on ECMO. If the patient on ECMO, if there's a bleeding, you have to do a bronchoscopy and remove everything, because if the blood remains there, it will get you will not able to open up the lungs. And then the delay in opening up the lungs will cause delay, furthermore ECMO supposed to be required. So then that case you have to take a balanced decision, and it is very easy to say, but then when you see practically, you will be difficult for you convince your chest physician to put a bronchoscope inside and clean up everything. Even if they put it, they will put it inside, says our blood hai वापस आ जाएंगे बस. That is what I have experienced enough time. I break my head with them, but still the best thing is that you learn bronchoscopy and do it. That's the simplest thing I feel. Yes. You have to do. See, first thing is that to stop bleeding, you have to do whatever is possible. First, simplest is do bronchoscopy, take the suck it out. If you can see some bleeder somewhere, you can cauterize it. Okay. If you feel that the blood is going from one particular lobe, I don't mind even you compromise that particular lobe. Also put a Fogarty and compromise that lobe. If you feel that there is going to be an arterial loose, go for a bronchial artery embolization. So whatever needs to be done to control bleeding, you have to do it. Okay, as a standard protocols. But don't just keep sitting on it, blaming the heparin. And that is what usually happens. You know, when you start practicing ECMO, you will realize this. Anywhere bleeding is there, all rest of the consultant, they sit and say, this is all because of your heparin. You stop ECMO or stop heparin. And then I say, okay, I'll stop ECMO and the patient will die. Is that acceptable? No. So in that case, you have to do whatever needs to be done in general, irrespective of heparin. You can't keep on blaming heparin for bleeding, because that needs to be done. That needs to be continued. So you can't help it. See, bleeding from cannula side, and that is going to be a small issue. You just compress them or take a pulse stitcher, and most of the time you will able to get rid of it. Or even if you can, even if you not able to get rid of it completely, the bleeding is going to be minor. You might require to be transfuse a bit, and then will be fine with that. Only GI bleed, yes, GI bleed can be a life-threatening at times. Again, if GI bleed, may go for by standard protocols. You start with the proton pump inhibitor infusions, give sucralfate or something for erosive gastritis if at all, duoscopy, upper GI scopy, lower GI scopy, mesenteric angiography. So what I mean to say is, I agree, bleeding can be aggravated by heparin. You have to first control heparin, first transfuse blood products, try to manage that. But if bleeding is not stopping, don't just sit saying that heparin is there, ECMO is there, so bleeding is there. No. Do all alternative measures to stop the bleeding. Yes, yes, yes. If bleeding is there, that's the standard protocol. That's what I discussed yesterday. If there's a bleeding, you come down to a SCT of 140 to 160. Don't go above 160. 140, 150 is desirable. Increase of flow. So that all you do. What I mean to say is that don't just sit on that it is heparin induced, it is ECMO related, so bleeding, so we can't do anything. Don't become helpless at that stage. Go ahead, do everything. If that is going to help, you will be benefited. Another pulmonary place, yes. Yes. This permanent place. So it is not possible for us to go through the introductory tube because we have 3.5 maximum force of that. Yes. So at that time it is not possible for us to put a bronchoscope to the tube. And little child in VA, for example, if you want to remove the introductory tube and go to the natural pathway of the natural passages, the other child is on heparin, so when you test the mucous surfaces, we may further cause problem. So at that time, what do you suggest for this? See, if bleeding is significant, then you have to take all to due care and you have to do it. See, when the patient on VA ECMO or VV ECMO, even if you stop ventilation for some time, that is not going to worsen the patient because you have backup of ECMO, if you have full flow of ECMO. So that is not going to be there. And you have to be more gentle and more careful if you want to do transmission. Definitely, I'll not put it as a first preference, but as what I say is, okay, if your bleeding is significant, you may not go for with a small bleeding, you go for it. But if you say that your bleeding is significant and the entire lung is become wide, then you have no choice than to do it. Okay. Yeah. Keep your team trained and ready. If you don't have ECMO cases, you have to do dummy cases, simulation, water drill, keep up the skill and reflexes. That is most important. If you don't see the case for 4 months or 6 months, you'll forget whatever I talked to you. Okay. So that is most important to keep your skills active. You have to do water drills, case runs, simulations, encourage teamwork, get everyone in the confidence. That's most important. Okay. You have to encourage teamwork. Initiate ECMO as early as possible. Thorough monitoring of circuit parameters is equally important. You have to keep yourself cool. That's most important. This all you realize when you start doing ECMO. At the end of 10 days, the relatives will keep on asking you why is not improving. The physician who has referred to you is also ask you why you are not improving. Then they'll come with an idea that keeps not improving, not going to serve, why you might make them spending money. So all these questions will come and you have to fully answer them. That's why you have to keep yourself very cool. You have to be optimistic. Don't become negative. Remember, the team leader has to be optimistic. If the team leader loses the hope, the entire team will lose the hope. And if the people work with a pessimistic attitude, then you always think that, no, if I put bronchoscope, there will be more bleeding. Let it be. We wait, naturally bleeding will stop. No, then it becomes absolutely negative. Your attitude becomes negative. So you have to be optimistic. You have to be patient. You have to be cool-minded. And think twice for the benefit and risk before you do any intervention. That's important. If you don't do it, what is going to happen? And if you do it, what is going to happen?
support with neurological evidence and maybe that we without before you go and hear your patient at this stage. So, are there any guidelines which have been published nationally, internationally to consider at what point of the time do you feel that there is a futility of continuing ECMO and you declare a patient well safe?
Yeah, good question. See, what happens is there's no guidelines for ECMO patient declaring brain dead. Is what we have guidelines for otherwise declaring brain dead. But what usually we do is we do 2 EEG at the interval of 24 to 48 or 24 hours usually. And if both the EEGs show flat line, pupils are non-reacting, brainstem reflexes are absent, after stopping all sedation and everything, then we call them as a brain dead. And then we usually motivate people to, either come down on ECMO and just keep them on ventilator or stop everything. Till the time you get the flow. Yeah, it's very difficult. It's very difficult to answer. Only thing is that, see, usually what thing we follow is cardiac patient for a ECMO for a cardiac patient, ECMO more than 10 days, okay, and patient is not showing signs of improvement, then is less likely to improve. Less likely to improve. We wait for 5 more additional days. In 15 days, if it does not improve, we tell them either go for a transplant or a assist device because ECMO, you are not getting improved in ECMO. That is number 1. Number 2, for a respiratory patient, more complex is respiratory patient other than cardiac patient. In respiratory patient, how much time to wait? The ideal guidelines is that because we have seen patient coming out at the end of 50 days, at the end of 60 days, at the end of 200 days also patient has come out. So again, that becomes difficult. But what you can do is at the end of 6 weeks, if there's still no improvement, at the end of 6 weeks, you can get a scan done. If the scan shows the changes of fibrosis, honeycombing, then definitely there is less likely that this patient is going to improve. Or you can go ahead with calculated risk and go ahead with the lung biopsy, and that biopsy proves that the fibrosis already occurred. Then in that case, you have to give them the options whether they want to go ahead with the lung transplant or they want to call it off. So target to achieve bare minimum to adequate SpO2, mixed venous saturation, mean arterial pressures, lactate levels, and what is important is whatever you are achieving, saturation, venous saturation, arterial pressure, lactate, it has to be defined at what cost. That is most important. You should know at what cost you are getting. If your saturation is 95, but with the flow of 6 liters, I don't want saturation of 95. I am happy with the flow of 4 liters, saturation 90. So whatever values you are getting, okay, you should always think about at what cost you are getting these values. Yeah. Especially when the bad person on ARDS, you put them on ECMO. I have been asked many times questions by physicians. We were maintaining saturation 90 and now also saturation 90. What big difference you have made? I said, do you got saturation of 90 at what cost? And at what cost I am getting saturation 90? That makes a difference. If the saturation of 100%, effect of 100%, PEEP of 16, peak pressure of 45. If you are getting saturation of 90, and if I am getting a saturation of 90 with the peak pressure less than 26 and a PEEP of 10 and a factor of 30, that makes a difference. So what is important is not this. What is important is at what cost we are reaching this, at what cost we are getting. That is most important because that considers the safety of the patient. Okay. Remember, plan and go, don't go, plan. That's important. You should know when to go and when not to go. That's the most important plan you should make it. You be aggressive for first 24 to 48 hours. Do whatever essential and must. Give fluids to maintain the flow. Add additional cannula. Try to stop bleeding. Transfuse blood products. Accept low acidity. Surgical intervention like ligation, impression. Whatever needs to be done, do everything in first 24 to 48 hours. Be very aggressive about it. Don't compromise on cannula size and circuit size. Okay, never think that if I put a big cannula, what will be the problems? I have to call surgeon to remove the cannula. That is if the person survives. If you don't put a big cannula, if the patient you don't get enough flow, if patient does not survive, there is no question of removing the cannula, isn't it? So you think about removing the cannula if the patient survives. So that's the most important. Don't compromise on cannula size and circuits. Avoid all kind of traumas, tracheal suction or suctioning, intubation trauma. Keep in mind, bleeding is an iatrogenic complication. I always label bleeding as an iatrogenic complication in ECMO. We do small intervention that leads to bleeding and then we blame heparin. That's not fair. Okay, is what we have done, and I'm telling you, I've seen that. One patient I've seen, patient was in Rajkot. The RMO, because the patient was already on rise to for 20-25 days, he changed the rise. He didn't thought a patient is on ECMO, so has to change the it's a very simple procedure. They hit that. And then he had a post-nasal bleed to the extent that the everything trickled down the trachea, the entire lung was flooded with the blood. And at that time I was in Mumbai, in fact. And then they said, no, now patient is worsened, tidal getting delivered is 30 ml only. So there's no point in continuing ECMO now. And then I said, wait, immediately I took a fight. I been to Rajkot. I told them to do bronchoscopy. Luckily, they listened to me. They did a 4-hour bronchoscopy, removed all the clots and everything. And finally, that patient after 5 days walked home. Okay. So that is what is most important. Small procedures you think, but that can create a lot of problems. Do not over-heparinize. Do not over or under infuse blood. That is again important. When I say hematocrit 45, don't listen to me half. I said hematocrit 45 if your saturation is less than 85 on the flow of 6 liters or 5 liters. That is what is most important. So, never transfer unstable patient without ECMO lines. That's again another mistake. Usually we do it. Okay. We feel that okay, patient is unstable, ECMO dalna hai, yahan pe bhej do. No, don't do that. You go there. If you don't want to stay there, don't stay there. I don't say you stay there. Go there, initiate ECMO, and then shift the patient. Because invariably, if you unstable patient try to shift without ECMO, you are going to lose them. So never transfer unstable patient without ECMO lines. Don't assume your perfusionists will manage the circuits. Again, another mistake. Okay. See, your patient is yours. I don't blame perfusionists. Sorry if you don't get hurted, but your patient is yours. So what feeling you will be having, that feeling may not be there with the perfusion for your patient unless your perfusionist becomes a hardcore ECMO specialist. That's the story is different. But if you have, if you are keeping some perfusionists which are not very interested in ECMO, so you don't expect them to do everything about it. So you have to always take care of your circuit yourself, and so you should be able to change circuit and manage circuit by yourself. What I mean to say is you should be able to manage circuit by yourself. Don't go for full support on VECMO unless you are forced to. Usually prefer to have partial ECMO support for VECMO so that you can maintain some pulsatility. But if that is not happening, then you go ahead with the full flow support also. Don't forget to put distal perfusion cannula for VECMO without end artery. So whenever you are using end arteries for a cannulation, you always put a distal perfusion cannula. So what are the cautions when you take with VECMO? Avoid full bypass, definitely. Maintain reasonably native pulmonary vein oxygenation supplies to coronaries. So if the lungs are normal, then you need not have to go by the rest ventilator settings for a VECMO. You can keep FiO2 40, FiO2 50 or FiO2 even 60 also. That is a safe FiO2. Because you are not dealing with damaged lung, you are dealing with the normal lungs in that case. So because your coronary is going to get blood from the native coronary is going to get blood from the native circulation to maintain good native PO2. Vent LA or LV if there is no forward flow. So in that case, you have to put a LA LV vent either in terms of atrial septostomy or put a surgical vent. Okay. If LA is vent, need to restrict the flow when weaning and remember effect on SpO2 because if the LA is vent and you are returning the blood of LA to your drainage, then your SpO2 is going to be falsely elevated. So you don't rely on that SpO2. Avoid return flow directed at the aortic valve. If you do return flow is directed directly to the aortic valve, it will cause aortic valve damage and then it cause aortic valve regurgitation. So see to it your cannula position should be proper. For VV-ECMO, don't think inotropic support is contraindication for VV-ECMO. Don't hesitate to put additional cannula, VVV, VAV, okay, or LA or LV vent. Don't harm the patient. Keep patients, organ will recover. That's the most important thing. You have to keep patients, organ usually recovers, but you have to see that you don't harm the patient by yourself. Do what is bare minimum and must. Remember, you cannot harm more than death. That's most important. You know that this person is going to die otherwise. So do whatever that can increase even 2% chance of his survival. So that is most important. So if we do surgery, he's going to die. What if you don't do surgery? He's going to die. Forget it. Go for it. We'll manage the bleeding. That's a usual thing which will come when you practice ECMO. So that's the reason I'm saying. Remember, you cannot harm the patient more than the death. ECMO is to, and most important, ECMO is to prolong life and not death. Don't just keep the patient on ECMO. अरे सर हमारे घर पे शादी है 5 दिन और खींच लो उसके बाद जाने दो. That's the usual thing that comes. I'm telling you. When we started ECMO, one of our neurosurgeons told me that there are very many patients who are neurologically not doing well and they want a postponed death. Can we do that medicine? No, you can't do that with ECMO. That message has to be very clear. The reason I tell you is, in fact, I wanted to discuss all this in ethical dialogue. Sorry, we didn't get the time. But the reason I told you that you are going to get this. Okay, I got a call from one of the prominent nephrologists. His auntie was not well. He had a marriage 3 days after of his son marriage. He didn't wanted that she will die before that. So they wanted to put her on ECMO. I refused. I said no, we can't do that. See, that's you should not do. The reason I am telling you for that is, in between, suppose you get an ECMO calls for 120 years young male, what will you do? We don't have as number of ventilators as we don't have ECMO numbers as we have ventilators. So you don't mind if one machine is get blocked. And I still remember for one of the famous politicians, stupidly I've been called for as a backup. I was there at that time, and then I lost one person, 21 years, who was malaria IDS. I couldn't go there and I lost that. And that's still I'm repenting for that. So that's the thing that you have to always keep in mind.